Hello, world. My name is Sasha Goodfriend. I am the content chair for the menstruation through menopause theme on Our Bodies, Ourselves today. And I am so excited to be joined here with one of my content experts, Sarah Pillone, on our menstruation through menopause team. And we are here for a very special interview with Dr. Shruthi Mahalingaiah, who is the Assistant Professor of Environmental, Reproductive, and Women's Health in the Department of Environmental Health at the Harvard Chan School of Public Health. She's here to talk to us about her research and how patients can advocate for themselves and their menstrual health on the daily. So thank you so much for being here.
Thank you.
When I'm not working with OBOS today, I'm also the director of MassNow, the Massachusetts chapter of the National Organization for Women. And we lead the Massachusetts Menstrual Equity Coalition. And so there's lots of overlap in these two worlds. And if you're excited about the conversation today, I encourage all of you to join our Menstrual Equity Summit happening Saturday, January 25th at Suffolk University, where Dr. Mahalingaiah will be joining one of our panels in the morning. So to be continued. This will just give you a taste of the conversation. But before we get started, I would love my colleague Sarah to introduce herself.
Hello, my name is Sarah. I am a former intern with Our Bodies, Ourselves Today, a current content expert on the menstrual cycle panel. I have interests especially in reproductive health, women's health justice, menstrual equity, and I look forward to a career in those fields.
Thank you, Sarah. So to begin, Dr. Mahalingaiah, we would love for you to tell us what brought you to choose environmental, reproductive, and women's health as your career.
Well, thank you, Sasha and Sarah, for inviting me today. And it's so great to talk with you. That's a big question. And I feel like throughout my life, even as a child, I kind of really loved being out in nature, going on hikes, and then walks outdoors, being in the environmental club in high school. And over my youth, we would visit my relatives in southern India every other year with some regularity. And I just felt a very distinct difference in air quality between kind of the New England air and South Indian air quality. And I just felt over my childhoods, particularly more physical symptoms of kind of that impact. And so some of those included just having problems kind of even breathing or taking walks during rush hour. So we would do our outdoor time in the early morning or in the evening, watching as traffic coordinators, and this is a long, long time ago where there were humans kind of directing traffic, wearing masks, having bloodshot eyes, developing kind of some respiratory symptoms, a little bit of cough, definitely staying indoors for high pollution, and then seeing that pollution on our kind of home with just the blackness and how often or with increasing frequency it would need to be cleaned and how quickly that would kind of recollect. I think that, and then another sentiment of seeing just a lot of green lush fields, particularly initially in both areas, kind of a tale of two cities or two worlds. And then over time, the green space where I would visit my family just kind of seemed to be reduced and reduced. And I had already known I wanted to study OBGYN, and I was in my OBGYN residency. And I had recently gotten married, and we had a reception in India, and right around my family's house, there were 5 infertility clinics that just had sprouted up. And my scientific mind was just asking, is there something going on between the level of pollution that I've physically experienced, coming back and forth, and all of these fertility problems? And, people would say, well, India has the most number of people. There can't be infertility. There's so many, that population is so enormous. How could that be? And to me, that was a big question to be asked. And our air quality is so much better in the New England area. And now, have been changes even with the wildfires from California and Canada. But I just started having an interest in answering, how is our environment interconnected with our health, specifically fertility, menstrual cycle health, health across the lifespan for females, because the endocrine system, which is a vital system in our bodies, takes information from not only our bodies, but also the world around us and our environment, from our homes to our circadian rhythms, to our diet, our exercise, our mental health, but also our environmental health. And so as I dove deeper into kind of the potential impacts of air pollution on gynecologic health and reproductive health in my fellowship and post-fellowship training, I just was committed to continuing to answer that question after we found signals in air pollution exposure and risk of infertility, and then air pollution exposures and the risk of fetal demise or late miscarriage. And of course, all of our findings were very related to the exposures within the United States, which are much lower than international areas. But I'm now interested in kind of bringing in those wide exposure distributions, not only globally with air pollution, but also across the country with specific kind of direct exposures. And we've heard about that a lot in the news, like with PFAS, with community exposures related to waste management or byproduct management, or even synthetic chemical production where safety may or may not have been known before chemicals were exposed to entire populations. And having that information before hopefully can help. And what I'm trying to understand as well is how much research is needed, and how much do we need to impact the values of our society to align with health, community health, public health, because I think the questions that I'm trying to answer won't have solutions unless we value our community health.
That's so cool that you, I feel like a lot of times climate change feels like it's far away, either that it's happening far away from us or that it's going to happen in decades to come. And that's very cool that it's not cool that you were able to experience the immediate impacts in your experience, but that you were able to make those connections between this isn't a future problem, this is a right now immediate, and where can we find solutions for your own community that you're living in and working with. And menstruation, I think, also similarly is seen as a mysterious practice that just happens without a lot of talking about it. People just manage their period or their menstrual cycle without asking questions or bringing attention to what products that they're using. And I'm excited to hear that we're able to maybe find some solutions for supporting more pregnancy or infertility experiences through not just starting at the moment of IVF or conception, but looking at our menstrual health before we even get to that conversation too. I'm curious if you found when you brought this up as what you wanted to study, how that was received by the medical community as well, where they were like, great, here you go. Here's where everyone who's studying environmentalism and menstruation is, so you can join them. Or did you have to carve out that space to draw the connections between your peers as well?
that is also a question that I've pondered, like, how do I go about this? And I think it has, and it has been met with, the environment, that's really not a major issue kind of thing, in terms of like in the past for me. I've kept it close to my heart in terms of my topic area of study. And I have definitely have to carve it out for myself, but in doing so, I think I've also challenged some of my own assumptions. Like in our medical textbooks, you see the uterus, fallopian tubes, and ovaries, and then you see it all in a little box. And in my mind, to me, there was this protective box around the uterus, fallopian tubes, and ovaries, like, oh, it's deep in the those organs are deep in the pelvis. And of course, those organs aren't all of what women's health are, but just in terms of, so many critical aspects of menstrual cycle and health across the lifespan with pregnancy and, even in the post-menopause. To me, I thought it was like deep in the pelvis, protected, like the Amazon rainforest. It's like protected, and should be pristine and untainted. And I had the privilege of spending some time in the rainforest in Ecuador. And unfortunately, what I saw very clearly was that the rainforest was not necessarily a place that was untouchable or that was protected for any reason. There was a lot of drilling, industrial inroads into kind of the area, as well as contamination from a variety of other things. And of course, it's a balance, industrial growth and supporting our ecosystem. And similarly, in some of the research I've been able to do with students and amazing collaborators is test that. What is in our menstrual endometrium? And on cycle day 1 of full flow on the during menstruation, that kind of is the most similar environment to the lining of the uterus or the endometrium. And so when we looked at first flow bleeding, the first 4 to 6 hours of bleeding, or an overnight collection on that first kind of heavy flow day, and it was a very small pilot study, what we saw is that anything can be detected in the endometrium that you wouldn't think about. So we saw kind of over-the-counter items like acetaminophen, face creams, and a whole host of chemicals. And this analysis was done with what's called an exposomics approach, where molecules are evaluated by a mass by charge ratio and then matched. Some of the matches are actual chemical structure matches, and others are aligned based on a variety of other factors in algorithm, let's just say. So we had some very close matches and some very distant matches, but there's a whole exposome in the endometrium, that place where potentially an embryo is implanting for growth, that's being bathed in what we bathe ourselves every day from our air, water, food supply, personal care products also. And, some of that is maybe that is what our bodies need to have. We are sampling our environment constantly. We are adapting. We are preparing for the future based on our chemosphere, our chemical environment, and a variety of other things. But sometimes maybe it's not as beneficial. And we detected PFAS chemicals in the menstrual endometrium. I would call it that for not having another precise word for it. And so, taking away that black box of protection, thinking about how interconnected we are, even at the level of the endometrium to our environment, is something that I would say I have had to carve out. Getting back to your main question, I think it's important to kind of carve out and share. And, I don't have an answer to all the implications of this. Part of this is probably important for our bodies to sample our environment, but also can be concerning, especially in areas of high exposure. So let's say It's exposure due to unregulated industrial waste or decreasing regulations, or in areas of the world that have no regulations. And I'm learning more, and I would like to hear more about and grow in understanding what's going on in other parts of the world as well. And I've just started hearing stories, which I won't share today, but I think the problems that maybe are faced globally sometimes may be even worse than in our own country. But at the same time, I think what I'm hearing stories from our own country, that there is a lot of concerning exposure because our values might not have been aligned, or our understanding that our waterways are, connected to all the waterways, not only locally, but geographically. Our water systems are connected across the earth. Our planetary systems are connected with, evaporation and precipitation. So we have to think very carefully and, um, about our bodies and the environment, because it's hard to know how many more moves we have as we move forward without kind of decontamination solutions and ameliorating what kind of the impacts from all of our natural industrial experiments now, to move forward in ways that can kind of balance what our value system is for economic growth, our value systems are for health, and how also that conversions on how we consider what it is to be female and what roles that is for society.
Wow, you think about getting a blood test routinely at your doctor's appointment, but you don't, where they, will measure your vitamin levels, but you don't think about checking your menstrual blood for what other chemical story is going on in your body, in your endometrium. Is that what
Yes.
we call it?
Yeah.
Great. Learning new words every day. I love it. So that's very exciting to think about the future of science, from what we can learn just from the first 6 hours of blood. Wow.
Right. I agree. Yeah. Thank you for that. And I appreciate you explaining that two-way interaction between our environment and ourselves as humans, that two-way influence, that it does go in both directions. And I also appreciate hearing about kind of what you've learned, some unknowns that you had, like thinking of our reproductive organs in that box, and learning throughout your work how it really was a part of our environment around us. And so what are some other kind of misconceptions and unknowns that you come across a lot as being a physician in your career? Because we know that there are a lot of misconceptions in women's health, and also in environmental health. So yeah, what are some of the common unknowns that you find?
That's a great question. And I think that oftentimes in my practice, caring for patients with fertility issues, concerns, or family building, the environment does come up. How can I have a healthier home? Or do you need to do a test? Is there something in the environment that is influencing me? And I think the hardest part, especially around just, the environmental piece, is there's some things we know, interventions you can do for air quality, water filtration. Some are easy to implement, and sometimes they're really hard to do at an individual level. So I think that's, one of the common questions. And then the other piece, like separately from that, is there isn't really a test that we commonly do for, at least in general clinical practice, for assessing your exposome, but that's an area of research I think is important. Across the board, though, no matter what educational background a person comes with, from, less than high school to multiple doctorates, advanced training, I think the menstrual cycle is still an enigma. And I teach every patient that's undergoing a treatment cycle about the menstrual cycle, so that everyone can understand why the medications work, how they work, how we're going to think about the cycle, you know. And so I'm happy to share a little bit about that now. So, you know, oftentimes all of at least my fertility practice is, and when we test the female partner, and of course the male partner is very important too, and there's many tests for the male partner, but for the female partner, we are testing ovarian function to start off with. And historically, all of the tests to look at the ovaries are timed to the menstrual cycle. And so we need to get them on between cycle days 2 and 4 of, you know, where cycle day 1 is full flow. Ideally cycle day 3, and cycle day 3 is the most reproducible time in the cycle where we understand how the pituitary or the brain is communicating with the ovaries. And so in order to interpret an estrogen level, we have to get the FSH or follicle stimulating hormone level in the secreted from the pituitary or brain. And that's on cycle day 3 with a whole host of other hormonal markers like LH, luteinizing hormone, also secreted in the anterior pituitary, thyroid function sometimes, TSH is the acronym for thyroid stimulating hormone, and then prolactin, which is another hormone that can be commonly off in young females of reproductive age and alter the communication. The menstrual cycle every day is different. It's very dynamic on what's happening. And so in younger females, what happens is that at the beginning of the cycle, starting even, you know, early cycle day 1, once the flow has happened, your brain is already recruiting your next egg for ovulation. And so the FSH is going up, your estrogen levels are kind of on their way up. They're kind of still a little bit lower on the first couple of days. And your body is recruiting a cohort or a group. I call it a team of eggs. Each egg is in a fluid-filled sac called a follicle, and they're developing on both sides. And only one egg gets to ovulate from its follicle out of this whole kind of team of eggs. And, you know, they're all competing against each other, and it's really hard. Only one gets to ovulate from 20. But in a fertility treatment cycle, especially for IVF, in vitro fertilization, we're trying to rescue all of those other follicles, which contain an egg, continue them growing, and try to get them to be mature at the time that we retrieve the eggs, around the same time ovulation would happen in the body. And so we talk a lot about that. We go through this dynamic process, and then of course, all of the changes that happen after, including complete retooling of that follicle or the support cells that supported the egg to grow will now make progesterone in the potential for an implantation to happen to support an ongoing pregnancy. And in the absence of that, a drop in all the hormones, and the cycle restarts anew. And I think that while I educate my patients around menstrual cycle dynamics for a fertility treatment cycle, we talk about success rates, the chance of a healthy egg or an abnormal fertilization leading to aneuploidy and miscarriage, and how all of that is normal. I think very few people understand how common miscarriage is and how much it increases with age. It's very impactful to educate ahead of time and destigmatize that, because it can be very impactful. It's a major loss to have a miscarriage after a fertility treatment cycle. And then for you know, younger maybe patients or patients who aren't attempting conception, who have an ovulation disorder, I think that disentangling what is normal, what they've experienced across their life, and what might be happening in terms of over exercising, under nutrition, or even limiting nutrition, but still having irregular periods and weight gain, and kind of disentangling what's going on, or having premature early menopause, and why that might be. And we always start with ovarian function tests, hormonal testing, and then trying to fit in what is going on with a diagnosis after that kind of background.
Thank you. I think I remember when I relearned recently about the menstrual cycle, being surprised at how many other hormones there are at play. I think there may be popular knowledge is that people think about the binary of hormones of estrogen and testosterone, which kind of makes our conversation across the country around sex and gender really binaried. And yet when we realize that there's so many other hormones levels that all need to function very specifically, it really does feel like a miracle that conception happens when there are so many challenges and so many levels that could be off, that it really takes a perfect concoction to for conception to happen.
I agree. And thinking about the complexity of menstruation, how, you know, every menstruator has a unique cycle, and that can vary from month to month, cycle to cycle. So I'm sure in your work that also kind of gets very complicated and interesting to see what your patients, what each menstruator, how their cycle varies and is unique to them, and how that affects, you know, your treatment and your care with them.
I agree. I think that the variation in the cycle is impacted by so many things. So we already know it's normal to have a little bit of irregularity right after your first period or menarche, and things kind of settle out to get into your rhythm, whether that's 35 days, 27 days, 23 days. Kind of things might change a little bit across the reproductive lifespan and then start changing back as early as early 40s with a cycle lengthening. While there's maybe fewer eggs to ovulate, it takes, you know, maybe a little longer to get an egg to come to that spot. Whereas, and then leading into menopause, where there's a cessation of ovulations. And I get questions a lot on, you know, I've had a little bit of cycle length variation. Does this mean I should get a workup? Or, you know, my period this month came 3 days later. It's always come on time. This is, you know, an emergency. And I think that it's, you know, with better education and kind of setting some parameters around what's normal, what's safe, can be helpful to reduce that kind of fear that's going on, especially, I mean, of course, at any stage, but there's all sorts of reasons to be afraid. And I agree that this fear also manifests in the environmental space in terms of like, oh, well, this chemical was shown to do this in an animal model. How does it affect humans? And I think kind of disentangling how much fear we should have and how far we should go as individuals is something that I am struggling with now in practice. Like, I want to give recommendations that are based on facts and research, and also limit the fear and concern for some people, as they will do anything to kind of create a safe environment for their growing family. But at the same time, I guess, another thing is to know when it's not normal. And so I would definitely say that for people who are having unprotected intercourse, like a week late in the setting of regular periods, you know, check a home pregnancy test. If you've had irregular periods, fewer than 8 cycles a year, fewer than 6, you're getting into the kind of more severe range. And definitely, I would say it's very severe when you've had fewer than 4 cycles a year, that, you know, without medications, without a workup to know, is there another endocrine problem going on? And depending on the person and their whole body health considerations, that can have different implications on bone health or uterine health at the endometrium.
That's a perfect segue into what I wanted to talk about next, because I think that there's a lot of people who don't, we want people to be able to know what's not normal for them, for their own body. And so there's endometriosis, there's PMDD, is it post menstrual,
Premenstrual.
premenstrual mood disorder?
Yes,
Mood.
it's premenstrual dysphoric disorder. I think that's the acronym. Yeah.
Thank you. Um, And there's cysts that can be on the ovaries. There can be, the lining can be growing on the outside of the uterus. There's so many different things that can be going on inside that box, so to speak, that we can't look into, that we want people to know when they should seek help and when they should see someone. So some of those guidelines you were just suggesting about, if you're getting between 4 and 8 periods a year, that's when you should maybe see a doctor. And it sounds like maybe the patients that you're working with already know that they have one of these things happening, or they find out through the process of working with you that they have something not normal or irregular going on. I'm wondering, could you speak a little bit to what that process of learning about themselves looks like for the patients, and how anyone who's listening might be able to see if any of those symptoms kind of align with things that they're experiencing as well?
We are so lucky in this state, I feel, to have kind of the healthcare coverage and the kind of access to care, at least in some way, to care here in Massachusetts. And so oftentimes I will be referred patients from primary care providers, from gynecology providers who want a little extra evaluation or counseling around an ovulation disorder, and then of course the infertility practice, where we can get to a diagnosis a little earlier, 6 months if you're over 35 and a year if you're younger. But for all of the other conditions, I think people come either having a suspected issue, at least to see me, but how do you get the suspected? When do you suspect, and how do you go get information and workup from your primary care? I think that is really the hardest part. And I do think that education is a piece of it. And I think that having providers that have also been educated is another piece. Having toolkits available is important. I think that there is a potential for, now that we have digital platforms, you can do so much on your phone. How much can you do? Can you get a diagnosis right at your point of care from answering questions that your doctor would have asked you, And sometimes I feel that these things can be really helpful, and sometimes I feel like in the wrong context, they can lead to more fear and inappropriate utilization of healthcare. But at the same time, I feel like there is a major gap. There are delays in getting a diagnosis of endometriosis, where the lining of the uterus, that endometrium, grows in other places, often the abdomen. It can be all over the body, really, but more rare. And every month there's bleeding that happens, and that bleeding in places it shouldn't be causes pain. It can cause pain. It can cause other problems, and can increasingly lead to disability over time, depending on the severity. So I think that there is a concern about getting an early diagnosis, being managed, and having counseling over risks of the management options and the benefits. And then I think, especially for endometriosis or any condition that can help or benefit from hormonal management, there's also a lot of misinformation about hormones. And I've had to do a lot of kind of education and sometimes begging and pleading, like, please take this, that you need to protect your uterus, kind of thing. But even with my degrees, I cannot compete with a Reddit thread. And so I'm having reflections on how do we work with this? How can I can give as much information as I can, one-on-one counseling, but sometimes I still can't engage the outcome that maybe I feel is the most beneficial for patients when they even do have access to the care, because of the misinformation or the lack of information online that pertains to the individual specifically, as opposed to that individual that's posting on Reddit or making TikTok videos, or that individual that's in my office that's had a full hormonal workup and has an intervention. So I'm not answering your question specifically,
Well,
but I think for every
in
condition,
a way,
yeah,
sorry,
no, go ahead.
it does sound like there's no checklist that someone can listen to and be like, oh, great, without doing any tests of my menstrual blood, I can check that off and like figure out a treatment plan. Every single person is different and every single person's body is different. And the only way to figure out the individual customized care plan is to talk to your doctor. So that
I
would be your gynecologist, and then hope that they can refer you to a specialist as well.
Yes, and I think many gynecologists and some primary cares can manage a lot of the conditions at an early level to support health. And I think that's really important. Not everyone needs to see a specialist like me. However, the other thing is that I do think there are ways to use your own digital tools to track your own body. I think body awareness is really important. And when patients come in with their bleeding log, with their pain log, with symptom logs, we can't figure out what's going on. Someone might have an ovulation disorder, but they're also having associated symptoms, bloating, pain, mood. It's really important to log and track the symptoms. There may be a time where we get really precise with our predictive algorithms, where we can be
I
able
want
to.
to give a shout out to my log that I'm going to try
Woo!
to start this year. Shout out to the cycle journal.
That is so cool. Yes. That is
Maybe
like,
you'll
for
have
example.
one coming your way also
Oh,
next time I
thank
see
you.
you.
Well, that's one example, and so not only for disease, but also for things that affect your everyday, the hormones are very powerful. People's behavior changes when they're close to ovulation. People's behavior can change, their mood can change when they're closer to a period, and everyone is different on how that manifests. And knowing your own body is going to be really helpful for you to set that baseline to know what's off, and to have regular check-ins. I think that one of the things I'm trying to emphasize in my writing as well as my communications with patients is the menstrual cycle is a vital sign. And so just like blood pressure, temperature, heart rate, the menstrual cycle is a vital sign. And so in a lot of our medical charting systems, you get the vital sign maybe once when you see the person every year, but it's also important to know, is it regular? Is it irregular? And that in and of itself can predict so much health across the lifespan. And getting to a place where the primary care doctors are tuning in, and I know they're very stressed out and there's a lot going on, but even to have self-advocacy around your own cycle. And I'm happy to share little tools that I've created with my research teams to kind of educate and also understand a little more in fun ways about the menstrual cycle. But, separately, common diseases I feel that go under evaluated are uterine fibroids, especially converging on heavy menstrual bleeding and anemia. There can be more suffering from people who are African American descent. And then endometriosis is one where there can be variable presentation, but especially in the setting of debilitating pain, having an evaluation. And that's unfortunately not a blood test. It includes imaging. It includes potentially a diagnostic surgery. And so each kind of gynecologic disorder, going back to the gyne system in a box, it can be very varied in how it manifests in the body. So sometimes you need hormone tests, sometimes you need full body imaging, sometimes you need a diagnostic surgery, or you need other specialized testing. And I think it really, really depends on what your symptoms are. So going back to kind of keeping that log for yourself, I think is really, really important.
So while we're not going to be diagnosing ourselves on a quick checklist, the best thing we can do is give our own menstrual care the care and attention that no doctor can do in terms of like meeting you every single day of your period and asking you how you feel. We can do that for ourselves. And I think so many of us also probably try to tune out all of the pain, tune out everything having to do with menstruation so that we you know, because there's so much shame and stigma and silence around menstruation. And so, as much as we can just be honest with ourselves and be in tune with ourselves and ask ourselves how we're feeling emotionally, physically, and not say, oh, well, that must be something else. Oh, well, it's not that big of a deal. I'll just take Advil, to acknowledge it and say that's our truth, um, and to be our own scientists, internal scientists, in terms of recording that every day of of the cycle. And you know, similarly, one of the bigger misconceptions that I've had to relearn in my work doing this is that the cycle is not just the time that we're bleeding for 4 to 7 days, it's the whole month. And thinking about how we're feeling during the times that we're not bleeding during other parts of our cycle as also not just being random. Maybe it is random, but maybe it's related to the concoction of hormones that are dancing within our gyne box, as I like to call it now.
Thank you so much. I had a great time talking with you both, and Grace too. It's really exciting to get asked questions from people with such a grounded mission around women's health advocacy as well, menstrual health. So I look forward to contributing in any way that I can.
Thank you. Thank you. I'm so excited for our listeners to hear about this because I think it's really under talked about in a lot of menstrual work in terms of the obos scene. I feel like we talk a lot about period poverty, but we don't get into the environmental impacts of a lot of the menstrual irregularities that people are experiencing. So this was a really great way to set that scene and start that conversation. And I hope we get to continue making the resources that don't already exist to get even deeper into it.